believe it or not, um, that was a big deal during the pandemic. Was many health information exchanges, despite their missions and what they did within their state, could not convince the state health department to share the immunization records with the health information exchange. It's what we call a policy barrier. They have it. They could technologically share it, but for whatever reason, their policy was we don't or can't.
Amazing.
The same thing is true at the VA. So any vaccines given by the VA, there's federal policy that prevents them from sharing that immunization record with the state immunization registry, the state Department of Health, which is ludicrous in 2022 from my perspective that we still have this. There are efforts to change that, but that's another example of a policy that's been on the books for decades that literally prevents the sharing of data, even though technologically we could make it happen.
Hello, and welcome to Informatics in the Round, a podcast designed to help everyone become a part of the dialogue about topics in biomedical informatics. I'm Kevin Johnson, physician and informatics researcher at the University of Pennsylvania, at KB Johnson MD on Twitter, and all over the web. My co-host, ST Bland, is a senior project manager at the Vanderbilt University Medical Center. Well, this episode promises to be incredibly informative for most of us. If there was nothing learned from the pandemic, it was at least the importance of data and helping us track disease progression and disease prevalence. I can't tell you how many times we went from place to place, and the first thing we did was pull up the heat map about how prevalent COVID was in the community where we were going. And I think we're not alone on that one. It also helped a lot of the states manage vaccine compliance within specific regions. Health information exchange was vital to many of the public health organizations around the country. And our speakers today were front and center during the pandemic, as well as, in some cases, decades before the pandemic, evangelizing this technology for the rest of us. We'll hear from them, and we'll discuss both what health information exchange is and what health information hubs could be doing for us going forward. I learned a ton during this podcast, including the leading excerpt. But there's much more covered by our guests, and I hope you enjoy it. ST and I are proud to introduce you to three guests during this episode. Brian Dixon is a professor of Indiana University's Richard M. Fairbanks School of Public Health and a world expert on public health information ecosystems, including how things are accomplished and the information or tech used to accomplish them. John Kansky is president and CEO at Indiana Health Information Exchange in Indianapolis, which is arguably the exemplar for health information exchanges around the world. Morgan Honey is executive VP of Contexture, an IT services and consulting group in Denver, and CEO of CSRI, the Consortium for State and Regional Interoperability, as well as CEO of the Colorado Regional Health Information Organization, or CORIO. Let's get to it. These guys have a lot to say, and it's time for you to hear it from them. I'm going to introduce each person by saying a little bit about who they are, and then you'll get a chance to hear their voices, and then they can correct all the things that I got wrong from LinkedIn. So I'll start with Brian Dixon. Brian is professor at Indiana University and at the Regan Street Institute, and is the Richard M. Fairbanks School of Public Health professor, as well as a world expert known to most in biomedical informatics on public health information ecosystems, including both how things are accomplished in the public health ecosystem and how information or technology is used to accomplish them. Hey, Brian.
Hey, Kevin.
I get that right?
You got it right.
All right. I'm 1 for 1. John Kansky is president and CEO of the Indiana Health Information Exchange in, of course, Indianapolis. IHI is arguably the exemplar for health information exchanges around the world, and John's been a major part of that effort for quite a few years now. Hey, John.
Morning. How you doing?
I'm doing well. How close did I get to your actual title?
Yeah, that's exactly right. And for the purposes of what we're talking about today, I'll add that I have some affiliations to Sequoia Project, eHealth Exchange, Regan Street Institute, Consortium for State and Regional Interoperability, and the Civitas Networks for Health. And it's just not just kind of how complicated and connected this ecosystem is.
You're not bored of being on boards, are you?
I can't. I can neither confirm nor deny that I am tired of being on boards.
Yeah, exactly. Morgan Honey is Executive VP of Contexture, which is an IT services and consulting group in Denver, and also is CEO of the CSRI, which stands for the Consortium for State and Regional Interoperability, as well as CEO of COREO, which is the Colorado Regional Health Information Organization. Hey, Morgan,
Hey, Kevin.
did I get
And
that right?
you did, and for just like John, for purposes for this discussion, Contexture is the health information exchange that serves Colorado and Arizona. Coreo is a subsidiary of Contexture, and prior to our merger last year to become Contexture, I served as the CEO of Coreo for the past 7 years. So, and much like John, a lot of different board relationships and various things in the industry. So great to be here this morning.
Thank you very much. Glad you could be here. ST Bland, I think everybody who listens to this podcast knows ST, who is now not going by Sarah, but going by ST.
Yep.
She explained that on the last episode. And she helps me run this podcast. She's also the senior project manager at Vanderbilt University Medical Center and is really an expert in precision medicine and the data that are attached to systems like All of Us that inform precision medicine.
Yeah, and I can disclose that I'm on no boards. So
You're doing it right.
yeah,
She's neither boring nor on a board,
exactly.
as you'll see through her irreverent humor, which occasionally makes an appearance.
Every once in a blue moon.
Every once in a blue moon. So I'm really excited about this conversation today. As many of us probably know, there's no way that you can be involved with biomedical informatics and not be aware of the need for interoperability and health information exchange, whether it's health information exchange, the verb, which is exchanging data, or health information exchange, the noun. Everybody also knows that the title of this podcast is Informatics in the Round. Typically that involves a musician, but we had so many people here who were experts that I thought the real round today needed to be the ball that we were going to pass back and forth between each other talking about information exchange. So if you're okay with that, I have a first question that I'm hoping we can answer, and I know this group is not going to need a lot of prompting, so I just want to get us started and then hear what we have to talk about. So health information exchange is obviously a serious and important issue today, but I'd be willing to bet you that most of the people listening don't fully appreciate either why it's so hard or why it's so serious. Anybody want to take on explaining to my mom why she should care about health information exchange?
I'll take. This is John. So first, I can't resist saying that my mom is 90, and she still tries clipping articles for me about healthcare and healthcare information technology. And I would say that it's pretty cute, but she does a reasonable job sometimes of latching onto meaningful things.
There you go.
But to answer your question, I mean, it's kind of the standard elevator pitch that we've probably all been doing for a decade or so. Healthcare just is notoriously fragmented. We all have personal experiences with data or information. It really is about the information, especially when you get down to the personal experience, not being there when you need it. It's the lab result that delayed your physician appointment for your mom, or it's the missing piece of information that you know in hindsight changed the course of treatment for you or someone in your family. And so that's why it's important. Why is it hard? Those who aren't in our business don't necessarily appreciate the technological complexities and the challenges of everybody calling the data elements the same thing at different organizations when you try to exchange them electronically. But people do have some sense of how complicated the healthcare system is. Just trying to get your insurance claims paid and interpreting your end of bill or whatever gives you some sense of the complexity of healthcare. Adding the technological component just makes it more complicated and therefore difficult.
Just to add on to that, so I think John gave a great introduction to the topic, but I think there's two things I would point out. Why it matters now, I think there's two reasons why it's probably even more important in 2022 than it has been in the past. One is that over time, we have seen on the health insurance market side, a number of changes to what's covered and what's not, and which providers are in network and what's not, right? So even as my mom ages and I'm helping her navigate the complex healthcare system, she is now, because of transparency laws, calling healthcare providers and saying, what's going to be covered? How much is it going to cost me? And she has to go to providers who are in different health system networks in order to have things done. Like there's one health system network where the main doctor specialist that she wanted to see is covered, but the nurse in his practice and the anesthesiologist in his practice is not part of her network, right? So this is going to become more of an issue as patients actually begin to kind of pre-screen doctors and figure out who's in their network and who's going to be covered and who's not. So I think the opportunity for even more fragmented data going forward will grow. And then the second thing is that in the wake of the COVID-19 pandemic, it became very obvious that the public health components of our health system are even further behind than healthcare delivery organizations. And so we saw many instances where lab results were being provided from clinics to public health via fax machines, where information was being manually recorded. It was being electronically recorded in the healthcare delivery system, but being manually reported to public health. Yep. And so as we come out of the pandemic, there's many efforts and ideas to say that's probably not where we should be in 2022. We need to have better interoperability or connectivity between the healthcare delivery part of our system and the public health part of our system.
Okay, Brian, I get the feeling that you and John's mothers should be getting together to create like this information resource about billing and information mapping and the two things that you just described.
And I was actually going to say that I'm a little jealous because my mom just retired last year from being a case manager and a clinical documentation specialist in hospitals. And so we talk about this all the time, and she tells me how wrong I am. So if you ever want to swap. But I want to take it back a little bit more. First of all, I'm thinking about the folks who think that their providers are already all connected. Their nephrologist is talking to their GI and to their PCP and to their dermatologist over at this practice. So let's take us back. Why aren't we there already?
I think the vast majority of people who have interfaced with the healthcare system probably have some level of assumption that connectivity already exists. I mean, when you walk into your doctor's office, you're lucky if they look you in the eye at all, because they're documenting everything in the computer, and computers, from the 21st century perspective, are all connected, right? And so I think that the general perception is that it's not a problem because all of the information is in the computer. To John's point and to Brian's point, it's way more complex than that. You've got extensive policy considerations that can vary from state to state. My organization works in Arizona and Colorado, and there are different state statutes that govern the way that we exchange data, both in Arizona and in Colorado. I know that in order for a good podcast, somebody has to be a provocateur. And I know that with me and John on this discussion, that you're not going to run short in that category, but
as I expected.
I was thinking about this over the weekend, Kevin, and it's like you look at I'm a big car guy. And so you look at like the evolution of electric vehicles, and the biggest challenge, or one of the biggest technical challenges in this industry is, like electric vehicles, um, if you are pulling up to a charging station, if every different model of electric vehicle had a different plug, the network of charging in the anywhere would not work. And that is a big technical barrier that we deal with in the interoperability space, is that in 2004, 2008, when EMRs, electronic medical record systems, were being pushed out, there were a lot of incentives for providers to adopt that technology. The challenge is that everybody, all the entire industry, developed their own technology. And even though we have standards, it is still very much like having an electric vehicle with a very custom plug that needs its own charging station. And so you constantly are driving around looking for, where's my plug, where's my plug. And so that's the analogy that I would throw out, is why technically we have some challenges, but we could go on all day long. John?
And listening to our conversation, and I think it is a decent explaining of the complexities and the why it doesn't work already. But I want to acknowledge that in our own clunky American free market way, we've kind of been stumbling forward for a good decade now, and that's kind of picking up pace. Now, putting TEFCA aside, I don't know if you want to even talk about what the heck that is, but that's the government getting into what I described as a free market attempt to make this problem less bad. There have been lots of moves forward. HIEs are getting better and stronger. Electronic health record software is, with encouragement from the federal government, is getting more interoperable. And more data is moving around in more different ways. Now, as we do in America, we're trying 17 things all at the same time, and arguing about which one's the right one, and creating an overly complicated ecosystem that kind of sort of works. It at least works way better than it did 5 years ago.
Yeah. And just to briefly add on, I would say that there are, to specifically respond to you, ST, I think there are pockets where there is some connectivity. So some people may actually have connectivity. So if you are, for example, a veteran and you're in the VA healthcare system and you only see VA-based providers, and you have 3 or 4 of them, they are probably connected. Now, the challenge is, of course, as soon as you go to a non-VA provider, now, of course, you've introduced more complexity. But there are pockets, like if you're in a metro area and all 3 of the providers that you see are part of the same healthcare system, they may actually be connected. But we know that for many people, the challenges come when they have acute events, or they're traveling, or they, are simply trying, or their insurance changes, and then they have to sort of pick a new provider, and then they start to run into a lot of these problems that we're talking about.
So you all did very good answering that. I'm very proud of you all.
They did a wonderful job. Morgan just like teed it all up and just sat there and watched it.
That electric car, exactly.
I gotta say though about the electric car, I have a Tesla. I am happy to go to Tesla chargers, superchargers. I know they work, but there are so many other variables, right? Not every charger is a supercharger, even though it has the right connection. My favorite is there's this whole kit that allows me to plug it into my house without a supercharger, but it never works. Why? Because it requires a certain amount of amps going into your line. So even though the outlet looks right, it will pop the fuse, the circuit, every single time I try to charge it. So even where we think there's interoperability, and this is a perfect segue, there kind of always isn't interoperability. Which leads me to say, so you've got this group CSRI. Does that mean that like not every state has this HIE thing? And if so, what is the issue? Clearly, the studies have demonstrated, you both have come up with examples for why it's absolutely critical. So what's the deal? And Brian just sits there laughing. Say, I want to hear this one.
Oh yeah. Okay. So let me. You threw a lot out there. So CSRI is a group that was formed by 6 of the largest, most capable health information exchange organizations, largely to do anything and everything that we could think of to move the ball forward. And one of the things that we're trying to do is to promote an idea we call health data utility, that every state should have a statewide health data utility that would do the kinds of things that HIEs have always done. And some things that big capable organizations like ours are starting to do. We want to encourage that thinking in every state in the union, because to your point, there isn't a health information exchange in every market or every state. And that's it's bad in a number of ways. Just for people who, we've been talking about this problem. If you have a so let me put a semicolon there, because one of the things that I think is super interesting, Brian was talking about the VA system. If you're VA within the system, your exchange is pretty good. If you stay within a like Epic to Epic exchange is pretty good. So if we're only talking about getting health care, that's kind of the state of things. So let me try to make 2 points, and hopefully not too nuanced. One is that if we're just talking about health care, it's super interesting to contrast places like Indiana or Maryland or Arizona or Colorado, where there's good health information exchange made via a not-for-profit health information exchange, and contrast that with a place like Northern California, where I think there's pretty decent exchange. That's because organizations there have doubled down on care equality and the capabilities of electronic health records, and worked hard at inter-organizational exchange without a not-for-profit or statewide health information exchange. That gets complicated, but I just want to acknowledge, if we're just talking about health care, then there are places where that gets done reasonably well, EHR to EHR, or via frameworks like care equality. But there's also places where that gets done well via a health information exchange.
Let me interrupt you for a second. So here I
Yeah.
am in Pennsylvania,
Yeah.
where we do not have a health information exchange.
You have several.
Health information exchange, right?
Yes.
And Pennsylvania has been described as California on the edges and Alabama in the middle. So does that mean that Pennsylvania is fine? We don't need any more health information exchange for healthcare, or does it mean something else?
The CSRI view of that world would be that Pennsylvania, well, this may be the Kansky version, so I don't want to get call the Kansky version is that Pennsylvania needs a statewide health data utility, which and I know some of the people that run the health information exchanges in Pennsylvania, and they might explain why that can't be, or can't be next year, or shouldn't be. But from a philosophical standpoint, Pennsylvania should have a statewide health data utility. Why? Because it isn't just about the point of care that we've been discussing. Maybe that's what the patient cares about. Maybe in Philadelphia, the hospitals are reasonably well connected for supporting care episodes. I can't really speak to that. But there's just so many needs for health data in a state, within state government, for public health, for the Medicaid program, but also businesses, employers. They want to know how healthy their workforce is. There's just lots of reasons to have statewide, curated, secure health data, and it goes well beyond supporting the point of care.
And I would build on that too. So this concept of the health data utility that we're pushing, it really, so John, this is a brainchild of John Kansky's, right? So him and David Horrocks from Maryland put their big brains together and came up with this concept. And what we're pushing is that there's a maturity model to the health data utility concept that is really never achievable, but there are things that you can do to move the ball down the field. And I'll point to a couple of different programs that we run here at Contexture. So bear with me while I get a little technical. As we think about health and healthcare, there are some foundational technologies and infrastructure that must be in place in order to ensure that you are matching patients appropriately, that you are connecting to the right endpoints, that you are gathering the right information and making the right relationships between patients and providers. That foundational infrastructure is also foundational to a number of other things. And I'll point to two that we work with here at Contexture.
But I'm going to stop you for just a second. Don't lose your train of thought. I don't understand the whole patient piece. I've got a social security number. It's unique. Match me on my social security number. What's the problem? Come on, dudes. Aren't you guys paying attention to what's going on in this country?
I'm laughing just on mute. Yes.
Okay, there it is.
Yeah. There's a number of challenges with Social Security number. One is it's voluntary for many people to provide it. So that's one thing. There are a good number of people in the country that don't have one.
What?
Yeah, and they also get recycled over time as people die and then new people are born. Their Social Security numbers get recycled. So the Social Security number doesn't make for a good universal healthcare identifier for the US. We don't have a universal healthcare identifier like other countries that are further, honestly, they're further down the road in developing a health data utility than we are. And some of them tend to be small countries, i.e., populations of 5 or 6 million people, like the size of a state, but not the size of the U.S. as a country. But we don't have universal healthcare identifiers, and there has been a reticence to endorse one and create one in the U.S.
Yeah, I'll add just to add to Brian's pile, add the transcription errors. You can't depend on it because human beings can't type that many digits without screwing up. And the fact that because of privacy, so many companies have appropriate policies that say we do not share social security numbers. Sorry, Brian, go ahead.
No, you're right. Those are two other very good reasons why Social Security number makes for a bad universal healthcare identifier.
Reverend Dixon has explained this problem to all of us and preached beautifully. So Morgan, what were you saying?
Well, and from somebody who spent more than a decade in healthcare operations, it is also standard operating procedure that if you don't give your Social Security number at that front desk, your default is 444-44-444 or 9999-9999. And so if you look for 4s and 9s in the interoperability space, there's going to be lots of them because that's how check-in procedures are trained. But
jeez.
I'll give you two examples of the health data utility maturity model here at Contexture. So one is this whole concept that the majority of healthcare costs are driven by things that aren't impacted by the healthcare system. We call that social determinants of health. So it's not your healthcare, but it's the things that happen to you as a person in your life that impact your health: education, poverty status, food deserts, childcare, transportation, you name it. So at Contexture, we have a program that we call Community Cares. It stands side by side with the Health Information Exchange, and it's all about the social determinants of health. It's about gathering the same type of information and exchanging the same type of information on the social care side of things that leverages the same infrastructure as the Health Information Exchange, those patient matching capabilities, the infrastructure to move data around. The other area that we provide services to the state of Arizona is by managing the Advanced Directives Registry. Again, same concept premise. When you want to be able to make available data, documentation that needs to be tied directly back to a patient and available at the point of care when it's most necessary. And so if you kind of peel back these onion layers about what do you need in order to make this stuff work from a technical perspective, the underlying infrastructure really always comes back from from Morgan Honey's biased perspective, the same type of technical functions that are required to run an effective health information exchange, patient matching, data storage, moving, interfaces to different types of endpoints for different types of technical platforms, relationships with communities, relationships with providers. Don't underestimate the value of contracting. Contract once, provide many services. And from my perspective, that's the foundation of the HDU maturity model.
We'll be back after this brief break. You're listening to Informatics in the Round. Welcome back to Informatics in the Round, a podcast about informatics for the rest of us. We've been discussing health information exchanges and the myth versus the reality of what is available. Now let's keep going and talk a little bit about the present and the future of this technology.
So I'm going to go back just a hair to some things that you said and recognize that I would say the average patient has no clue that their health data are being utilized in this way. Especially with the politicization of healthcare privacy. And we've talked about that in a couple of other podcasts recently around the Dobbs decision and Roe v. Wade. I would say a lot of people don't have any clue that their healthcare data are being used outside of the healthcare system for things like businesses, social determinants of health, statewide information. They might to a little degree, maybe at aggregate levels, but what does that look like? Help an average patient understand what their data is doing and where it's going in these circumstances.
Well, I think I would start by realizing that all of our data, on the one hand, we should strive as a country to respect privacy and policies to protect privacy appropriately. But I think we have to understand that in the world that we live in, there's a certain amount to a degree to which our data is just going to be used for stuff, hopefully appropriately, constructively. So sorry for that long setup. I don't know if you've had this experience, but we're increasingly asked to sign documents electronically, financial documents, insurance documents. Yep. And when I've been asked to do that and I have to prove who I am, it's astonishing what they know about you to be able to establish your identity. Have you ever lived at this address? Wow, yeah, when I was in college. Have you ever bought property in this zip code? Yeah, 47 years ago. How did you know that? So the point being, I was glad to be able to confirm my identity, and I wouldn't want someone else to have been able to sign that document, but there was a creative use of my data. So there are always going to be humans who are going to just not want their data to be used for any reason. I don't think that's appropriate. But I do think it's appropriate for us to have a reasonable amount of control and awareness of how our data is being used. So it's just the world we live in where the amount of data being generated by the second is just growing beyond the capacity of humans to comprehend. And we're trying to constructively and judiciously and fairly use it within laws and ethics.
Okay, so we have all these data. We have this idea of a utility or a hub. We have monkeypox. Has anybody been able to demonstrate being able to slow down the progression of monkeypox? Because this is what you think it's for, right? You have a public health threat. You have a limited vaccine supply. You've got this wonderful set of utilities, and maybe there's a few states who don't buy why you need it or not. What are you doing to combat monkeypox? Why? What's making that one hard, or is it solved?
So I wish I would have paid closer attention to that conference call this week, because I know the Department of Health has reached out to our organization specifically about monkeypox. I'll use the recent COVID experience though as an example of when you the old Chinese proverb, the best time to plant a tree is 20 years ago. Because of the health information infrastructure that exists in Indiana and existed prior to the pandemic, the Department of Health was able to say, first of all, we need all positive and negative testing data from one data stream, the Health Information Exchange. And then when we finally had vaccinations, they were able to say, here's all the vaccination records. Please make them available to the healthcare system so healthcare providers can, through the Health Information Exchange, be aware of the patient's immunization status. So that isn't a really direct answer to your question or a direct answer from monkeypox experience, but I think it starts to demonstrate how the ability to having that infrastructure in every sense of the word, of data exchange can help prevent not just communicable disease, but chronic and daily healthcare.
Let me give you another example. So monkeypox is challenging for me because it's like Groundhog Day, right? I mean, it's a different crisis, but it's not the same problems with COVID and all of the data exchange that we dealt with there. It's the exact same issue. But one of the programs that we've been doing with the state of Colorado, to your point, Kevin, is so I'll use myself as an example. I got my COVID vaccine literally on the side of the road in Clear Creek County, Colorado. It was delivered by
people in Colorado do.
It was through the public health department, and they had a roadside clinic set up at a Colorado Department of Transportation, salt silo. And so me and my wife drove up to the mountains, got a COVID vaccine, filled out the little piece of paper, handed it to the person, and got shot right there on the side of the road. The fallacy with that process is that, and I swear to God, I will get to your question, is that I can put anything on that piece of paper that I want, right? Like, it's just me sitting in my car filling this out. I can put any demographic, I could put any address, I could put anything in those boxes that I want. With the Health Information Exchange and the health data utility infrastructure, whatever I didn't put, or if I put something wrong, can be verified using the number of sources that we have for identity. Now, here's my point, is when you ask about have we seen impacts of using this technology? Yes. The example is that in Colorado, at the beginning, when vaccines or when COVID testing became available, the public health department and the healthcare community in general, they could see how many people were being tested. They could see how many people were being immunized, but they didn't have a reliable source for seeing the details or verifying the details of who those people were. Where were they coming from? What did they look like? And so one of the things that we did with the state was to take that information from the public health department and give them back additional information about race, gender, ethnicity, location of residence, so that our public health department could be more precise in where they were trying to outreach for testing and vaccinations, whereas otherwise they're just dealing with numerators and denominators of general population.
And I would add that monkeypox illustrates why it's important to think about health data utilities as opposed to our previous notions of a health information exchange, because I think, to John's point earlier, health information exchange notions of the past have been really focused on clinical care, connecting so that care providers can share information, but kind of didn't think really about the public health system. Monkeypox illustrates all those components of why it's important to think about health data utility as serving public health and government and social service and clinical care all at the same time. Because when monkeypox, so first of all, the monkeypox diagnosis existed before the outbreak. So from a diagnostic perspective, you could start to pick up on those in in a data infrastructure, as Morgan illustrated. Tests, though, were only being done at the very beginning of this, were only being done by CDC and state health labs. Over time, right, we just saw a few weeks ago that Quest and LabCorp and the big major laboratories started to do this testing. So as the testing begins to ramp up, then you start having results that can flow through the system. So if you didn't have any connection to state public health and public health labs, then you wouldn't know about the testing that was going on in the very early days of the epidemic. So it's important to recognize that we have to think holistically and make sure that our whole health system is connected to these entities so that you can pick up on the diagnosis. Same thing with immunizations. Immunizations tend to go into public health immunization registries in each state. So if those are continue to be silos of information, which, for the last 30 years, most of them have been silos within a state. They haven't really talked to one another. Forget healthcare for a minute. Like even the public health immunization registries don't really interoperate with each other and share information. And so as we're moving forward, that's one of the things public health is wrestling with, is how do we enable exchange? Because if you live in Chicagoland or you live in New York City, you've got people who live in multiple states in your metropolitan area. And so only having New York State immunization registry for people who have an address in New York probably wouldn't help New York City very much.
One of the things you said there that's really fascinating is the need for the hub is that despite what John just said about, finding an address for the house that you purchased 40 years ago, there are firewalls that prevent the same state from being able to use data that are literally sitting in the same office sometimes on different servers. Mm-hmm. Because you'd think, for example, somebody called me last week and said, regarding monkeypox, I had the smallpox vaccine when I was a child. Am I protected? So I went to the CDC website and I read some things. And then it occurred to me that if it were true, wouldn't we be getting some information from our state that said, there is this outbreak, good news, you're covered? I gather that that's virtually impossible in most states right now. By the way, smallpox vaccine has not been shown, for those of us who have had one more than 10 years ago, to be really clearly protective against monkeypox. So I wanted to make sure I got that clear. But wouldn't you have thought that there would be a way to have that communication proactively because you have these two databases? And I believe the answer is no, there actually isn't a way. Is that right?
Well, not only is this, you're making me think of something that we haven't really talked about clearly, which is policy barriers, which is to your point. While there are databases that are being shared that Americans are not aware of, maybe in the financial industry, there are databases that are not being shared, sometimes because there's a simple policy within, for example, state government that says we can't share that. Believe it or not, that was a big deal during the pandemic. Was many health information exchanges, despite their missions and what they did within their state, could not convince the state health department to share the immunization records with the health information exchange. It's what we call a policy barrier. They have it. They could technologically share it, but for whatever reason, their policy was we don't or can't.
Amazing.
The same thing is true at the VA. So any vaccines given by the VA, there's federal policy that prevents them from sharing that immunization record with the state immunization registry, the state Department of Health, which is ludicrous in 2022 from my perspective that we still have this. There are efforts to change that, but that's another example of a policy that's been on the books for decades that literally prevents the sharing of data, even though technologically we could make it happen.
Well, so why even collect the data if we already have these, firewalls in place that prevent the use of the data and the use cases that we can all imagine as, lay people consenting for this stuff?
Well, my answer to that one is, if you ever have an opportunity to collect the data within constraints, even if they're too tight, collect the data, because policies can change, and opportunities to build the infrastructure or build the path to getting the data and coding it and making it useful. Even for one or two things, you can use it for three or four things later. Yeah, it's just the policy barriers are perhaps the most frustrating. This may be going too deep, but I'll call it out real quickly. Is behavioral health data is incredibly important, and because the federal government protects that data differently than it protects all other healthcare data. The unintended consequences of that, I'm oversimplifying, is that organizations that provide behavioral health care often are just left out of the information exchange ecosystem to the detriment of patients and society. So what seemed like a good policy, because it seemed like protecting that information was especially important, just making a different set of rules. We spent the last health information exchanges and healthcare providers and others have spent a decade trying to get the federal government to harmonize HIPAA with the different rules that protect that information so that it could be more of an ecosystem that functions.
And I'm gonna pick on John just a little bit here because I can. He's a long ways away from me. There's also policy interpretation. And so what John just said is behavioral health information. It's actually not behavioral health information, it's substance use information, which is largely provided by the behavioral health system. But if you've got the interpretation by behavioral health providers that everything is covered under 42 CFR Part 2, which is the privacy policy that covers substance use data, then you've got a huge portion of the healthcare ecosystem with incredibly important information at their fingertips that says, I'm sorry, everything I do is covered under this different policy.
So you just brought up a good point about who's protecting it. Do you think that sometimes some of this information is withheld or not exchanged because it helps protect them from liability?
There's sometimes it's liability. Sometimes it's the perception of liability or real liability. Sometimes it's the perception of what they think. I don't think I'm allowed to share this. Well, but you are. You just don't understand the rules. And in the darkest hour, there's competitive reasons that I really just prefer not to share this data because I don't want to help you. Yeah. Now, that's what led to, oh gosh, let's not talk about information blocking. I
don't think I brought it up there, John.
Oh, was that my out loud voice?
I believe it was.
Oh, sorry. There's a perception that there are organizations that don't really want to share their data. I'm sure there are those. We now have federal regulation aimed at that problem that I'm not a big fan of trying to fix that with regulation. But in general, I think organizations are trying to share data. They're not trying not to share data.
And I want to go back real quick since you brought up HIPAA.
Which stands for what, by the way?
Which one of you wants to take that?
Health Insurance Portability and Accountability Act, but that does not help you understand what it is.
Yeah.
We covered it in a previous podcast. Go back and listen to the episode with Brad Malin and Ellen Clayton, and you'll hear a lot about HIPAA, privacy, and security.
And so because we've talked about it on this podcast before, people are probably assuming, oh my gosh, my HIPAA, y'all are violating HIPAA by sharing this data. And we keep saying this data, or these data. Are we sharing, or are you sharing row level or patient level information data that would violate HIPAA, or is there still a privacy protection there when we're sharing data amongst different organizations?
There's absolutely privacy protections, and none of us could do what we do without complying not only with HIPAA privacy and security rules, but any and all regulations in our state. So we take that stuff extremely seriously. And and HIPAA is after, oh my gosh, HIPAA privacy was 2003. The law was passed in 1996. As a country, we've kind of figured out how to live under HIPAA in a way that allows the healthcare system to function and respect privacy. Now, the funny thing is, and now this is your fault, is the way that I explain information blocking is it's the bookend to HIPAA. So we now have a federal regulation in this country that says to healthcare providers and others, if you share information when you're not supposed to, you get in trouble. And now we have a regulation in information blocking that says if you don't share information when you are supposed to, you get in trouble. So, I mean, as if healthcare wasn't regulated enough, now everybody has to operate somehow between those two guardrails.
Oh, it's actually worse than that, right? I mean, HIPAA protects covered entities. So the other part of that situation is there's this third guardrail, which is a cliff with no guardrail, which is if you, patient, were foolish enough to think that the data that you gave some random company is protected, you're in trouble.
Yes, yes. What Kevin is saying is important.
Okay, I got one. There it is. Okay, so let me ask another question here. So, um, I'm gonna date myself by saying one of my favorite scenes in any movie for the last 20 years was Tom Cruise in Minority Report, where he's walking through the mall. You guys remember this? And there's all these targeted ads, which, by the way, are very reminiscent now of every experience I ever have on Facebook. But as he's walking through and it's saying things like, "Hey there, whatever your name is, your size 10.5 Timberlands are in stock," right? So I fully imagine the day when we were going to be able to use health information exchange, um, walk into the doctor's office, and have some kind of a screen or headset or something where it says things like, you're behind on this vaccine, and the hospital doesn't have to deal with it. The health system kind of allows this. Or, did you know that the water, the brown water that you were exposed to back in 2022, or the high levels of toxic chemicals that were found in your water in Flint, Michigan, now can be treated with some new X, Y, or Z medicine? Please call this number or click this button to find out. I fully expected that we would have a public health infrastructure that could actually be predictive and preventive. Are we even heading close to that, Brian, as one of the world's experts in public health infrastructures?
We've only taken baby steps in that direction. You know, we haven't invested in the preventative side of all of this the way that we should have, right? So, really the focus has been more on, provider to provider exchange and, especially in acute care situations. We do now have, though, and Morgan and John may be able to talk about some specific examples. We do have some elements of what you described that happen. So, for example, we do have instances where public health can we have instances where public health can identify a population of interest and look more into them, not necessarily contact them and say, like, you were exposed to this 20 years ago. We're not quite there yet. But we can look at populations. We can, on the research side, we use the data to identify individuals that might be eligible for a trial. So to your point, we do now have some instances where we can identify people who might benefit from some new treatment that's coming out. We also can use the data to identify individuals who might be behind on their vaccines. That happens as more and more vaccine registries have both adults and children in them. For a long time, we were prioritizing children, but now adults are being added to the mix, and we can say things like, "Hey, you're due for this." So we have made, I would say, some baby steps in this direction, but there's a lot more we can do and could do with health data utilities that we couldn't necessarily do with just an HIE that served the primarily clinical organizations in the community.
Wow.
Brian, I think weren't you involved in some of the pioneering work on surveillance as well?
Yes. So from a surveillance perspective, yeah, we have made great strides. But I think what Kevin's getting at, which is the next step, which is you walk in and they're like, "Hey, you're due for this." Like we've done projects on that where we can have, for example, a medical assistant review your records with you and say, hey, you're due for this like third dose of the HPV vaccine while you're in today. Would you like to go ahead and get that done? We've done that in some pilot work, but we haven't operationalized that across the health system.
When
Well,
you say we, do you mean you in Indiana or do you mean the United States?
Both. Like we haven't actually, operationalized it, more in more than one sort of like health setting, right? So we've done some very interesting work, but it hasn't quite scale. Surveillance has scaled. The preventative side, though, remains in pockets. And that, I think, is both an exciting opportunity for us, but also, to Kevin's point, I think it's something we need to recognize as something we haven't really attended to this point.
well, and I'm going to continue to be the provocateur. So to go back to Kevin's example, the reason that you get those targeted ads on Facebook is because the people selling the product pay to have it placed there, and with the anticipation that you're going to buy something. So the real issue that we're talking about here as it translates to healthcare is, until there are financial incentives and a business model that can be applied to actually making that type of functionality worthwhile to the people who are providing those services, either the health data utility or the health system itself, until the financing mechanism changes to incentivize those types of services being put out there. Morgan, you need your immunization. Morgan, you need your follow-up. Then the financing is backwards, and it's not the same as the targeted ad on Facebook.
Well, and this could be the topic for a future podcast. If value-based care really becomes the way we pay for healthcare in the United States, for the first time in 100 years, the providers and public health would be on the same financial side.
Yeah, no, I agree. My other vision, here's my other one. So some of you know that I was a part of the Health Information Exchange in southwestern Tennessee called the Mid-South eHealth Alliance. And we had this vision, my use case that I wanted to demonstrate. When we first came up, we noticed that there were patients who had multiple ED visits, emergency department visits, scattered in time and space. And we decided to look to see whether we could see evidence of non-accidental trauma patterns. Because one of the ways in which you might expect a woman who's being abused by a spouse to present is that they went to one ED with one thing, another ED with another thing, so that nobody could figure out that there's a pattern. And in fact, we found some. At the time, we were not able to ever recontact. Talk to me about that. I mean, these are my tax dollars. I'd love to be recontacted for things that a public health environment could tell me about my health or my children's health. Are we, to your point about policy, is there a general willingness, excitement about being able to use health information exchange in the way I just described, or is it totally a pipe dream and there's just too many people and too many policies that would have to change for that to happen?
I don't want to take that hot potato, and it is a hot.
That's all
potato.
I'm about, baby, is hot potatoes.
But I'll tell you what, a very contemporary topic in a post-Roe era is the idea of using healthcare data for law enforcement is a slippery slope and a little uncomfortable.
Well, I mean, ideally, instead, I would say there is excitement from public health. People are very excited about the opportunities for health data utilities and health information exchange writ large, because there are many of them. Public health often administers the WIC program, the Women, Infants, and Children's programs. They operationalize nutrition-based programs. They work with other entities in state government and social care organizations to provide a safety net. And so they would love, and they're excited about the opportunities to get people connected to the resources that they need. So I'll put it that way. So I do think, Morgan alluded to this earlier when talking about the social determinants of health, or as we're now calling them, the structural determinants of health, to identify populations that would benefit from the services that are available in their community and get them connected to those. I think there's a real desire to do that I think that for many of the reasons that we've talked about, it's been challenging. Again, there have been some efforts to move in that direction. It's happening to a small degree in some places, but I do think that that potentially exists. Maybe not necessarily to sort of say, based on your profile, we think that you're being abused, because it can be very hard to, that's a trickier situation. To reach out to that person, because you also don't want to put them in jeopardy by alerting people around them that they may be in danger. But for connecting individuals who are in food deserts to food-based resources or food pantries in their area, or connecting individuals who might benefit from a tobacco cessation program in their community, and help them get connected to that, there's a lot of interest and hope that that's the direction we're moving towards as we build things like health data utilities.
That's great. Thank you. I feel better now. Well, I want to get us wrapped up here. This has been incredibly informative. I just want to give everybody a chance to sort of give us that final piece of information that they wanted to make sure the audience knew about this topic. Before we do that, I think I'm going to ask ST if she has any questions she wants to make sure we address.
I wonder if you guys have often thought about, is there a point where maybe we go too far in prevention or surveillance that we do need to be careful about? The police thing is a good idea, but also, does it take away people's choice in being able to want certain services or not, and being surveilled?
Well, in general, I would just call on listeners to um, being able to have information about you shared is in your best interest, the best interest of quality healthcare, the best interest of your community's public health. And so try to resist paranoia, because people are trying to do the right thing. And that's not to say that people in our business don't need to guard against and advocate for policy that prevents weird, creepy things from happening with information. But don't be it's in your best interest for your information to be available to those making care decisions about you.
Well stated.
Yeah.
Morgan?
I would just build on what John just said. I mean, I think you have the framework, the policy framework of HIPAA and other privacy policies that govern the way that this whole ecosystem works. But you also have the Hippocratic Oath that every medical professional has taken as well, and that is do no harm. And I think that we all approach this work through that same lens of we're here to do good, and to do no harm within the policy framework. And for the one thing I can guarantee you is that everybody who works in this industry is here for the mission, to try to improve the healthcare ecosystem in general, because we recognize that there's plenty of opportunity for that. And as a patient, I emphatically opt in every time that I take my kids to the doctor, or my wife goes, or I go. I have to sign a new disclosure. I'm emphatic, and I go so far as to thank the providers for being a part of the health information exchange.
Very cool. Brian, you have the last word.
I would say that our conversation today has largely been in the American context. We've been talking about states and the nation, and that's important. That probably touches most of our listeners because they live in the US. But I would say that these same conversations are happening around the world, and there are a number of countries that have HIE networks that are mature and robust, and several of them that probably meet our definition of health data utility. And so as we move forward as a country, I would also say we can look to some examples that are outside the US for some guidance and maybe some partnership and collaboration to sort of say, hey, how did you address this issue? Maybe we could learn from that, because other countries are trying to learn from their nearest neighbors in different continents, as they move forward, both with the introduction of health IT in general, and then they want to get to interoperability shortly thereafter.
You know, we started this off with some discussion about my husband having COVID pneumonia in Barcelona. And you're bringing up the most important piece of this, which is the idea that we should always be thinking globally, even if we're acting locally, so that we can get to a place where, with the world being as small as it is, you don't have to worry about the fact that you're someplace else. Your information should be available. So this has been very informative. Thanks everybody a lot for this. One final request from one of you, any one of you. I need one good joke about health information exchange.
I got nothing. There's got to be one that starts with like two patients walk into a doctor's office, but I don't have the punchline.
No. Morgan, anything? ST?
No, I got nothing for you.
What a bunch of geeks.
Nerds.
Yeah, right.
I could tell you a joke about just about anything else in the world, but not health information exchange.
Yeah. All the jokes
This is no laughing matter, Kevin.
There it is. There it is. That's a joke. You know. Okay, everybody. Well, thanks a lot. This has been terrific. Thank you for listening. Incidentally, if you're interested in seeing some of this discussion and not just hearing about it, check out our Facebook site or our TikTok channel or our YouTube channel, where we've put some of the tastiest bits for public consumption. Good stuff, I think. By the way, we've got a couple of great topics queued up, so please stay tuned. Till next time, stay well, get your booster, and keep a positive outlook on life. Science, it'll cure what ails you.